Okay. So, morning. So this is the hair chapter. There's also other skin appendages, so there's some miscellaneous things thrown in to include hair shaft abnormalities. So there's a couple of those in here. So this first one is supposed to just be pattern alopecia, and this one actually is decent for it. So from scan, it's hard to really make out the larger terminal hairs because they're all miniaturized, and so that's one of the first things you see off the bat is that you get miniaturization of the follicular units, and you start to get a pretty pronounced shift of the terminal hairs all going to vellus hairs. That's part of the process of what's going on. So that's what you see on the microscope. And what you also don't see, because that's usually very important when it comes to hair, is from scan you're not really seeing tons of inflammation, you're not seeing tons of newts or lymphs or anything anywhere, and you don't really see tons of scarring either, really any scarring. Now of course with hair stuff there's also a lot of overlap, so it is possible to have a scarring thing and have pattern alopecia, but in this case you're not seeing a lot of those features. And so then when you get in a little bit closer, you can start to see that there are still quite a few hairs in here, but they're all miniaturized, they're all small. I mean, by definition, a terminal hair, which you don't really need to know this, is like greater than 0.06 millimeters, and vellus hair is less than 0.03 millimeters. And then there's things called indeterminate hairs that are in between those, and none of that really matters except to point out the fact that, I mean, you can actually measure the hair shaft diameter, and that can tell you whether it's terminal or vellus hair, but you don't really need to do that because you can just see how tiny that is when you compare this to this guy here. This is a remaining terminal hair, but almost all of these are just tons and tons of really small hairs. Now you got to be careful you don't confuse these little eccrine glands with hairs, but so tons of small, miniaturization of the follicular units, no scarring, no inflammation. You will have a little shift towards telogen hairs and catagen hairs with a lot of these conditions, and that's pretty much it. And again with that vellus hairs, this hair shaft diameter starts to get really, really small, and it even gets smaller than the inner root sheath width. So like this here, for example. So it's even smaller than that. So that is pattern alopecia, and sometimes it's subtle, sometimes it's very pronounced. Okay. This is one of those sort of extras in this chapter. This is Langerhans cell histiocytosis, and basically what you're seeing here is a bunch of inflammatory cells that are predominantly at the infundibular location of the hair follicle. And from scan they just look a little bit odd, and you have to trust me on that, but here for example these are dark blue small lymphocytes, whereas most of this are these kind of paler, larger cells with a little bit more cytoplasm. And so as you start to get an eye for it, you figure out that that's not quite what you'd expect to see with a bunch of pink neutrophils or blue lymphocytes. So it doesn't quite look like a acute Lichen planopilaris or anything else with a bunch of inflammatory cells around the infundibulum. So again, getting closer in, you kind of start to make out these are a little larger cells, and it's just not right. There is this sort of crust and maybe some neutrophils over top of it, which you can often get that crust with the Langerhans cell histiocytosis. And then getting in even closer, and actually I'll just get really close. Sometimes it takes a while to find the perfect examples of the Langerhans cells, but here is a reasonable example where basically you get this reniform or kidney-shaped nucleus, a little cleft in it. Sometimes, depending on how it's oriented, I almost think it looks more like a coffee bean. And then it usually has a decent amount of cytoplasm. So maybe that's an okay one. This one's got a little bit of a cleft to it. So you start to, find these around, and you can say, oh, it's, these are a bunch of Langerhans cells, not neutrophils or lymphocytes or anything like that. So this must be Langerhans cell histiocytosis because there's so many of them. So this is a hair shaft, and there's two of these in this box. This, I think, is actually a better example, having looked through them. But this is supposed to be an exclamation point hair, and clinically that is an indicator of alopecia areata. And what that means is that it looks like a little exclamation point, mainly the top part of it. You don't see the little dot that's below it, but you're seeing this darkly pigmented kind of normal hair that's normal width, and then all of a sudden it tapers down and actually starts to lose the pigment. And that's what you start to see here as it gets finer and skinnier and lighter in color until it gets to almost like a pencil point hair. And you also see this in Anagen effluvium, and that's because alopecia areata is kind of a type of Anagen effluvium, which means that you're losing abruptly anagen hairs. They're not switching to telogen as in a telogen effluvium. They're just being abruptly kind of stopping, they're not growing anymore, and they fall out because they break easily. So there's some subtle differences between the two, but usually, most commonly we're seeing this with alopecia areata. So that's an exclamation point hair. Okay, this one is alopecia mucinosa, or follicular mucinosis, and even from scan you can start to see that there are just these large pools of bluish mucin within the follicular structure. So not interstitial mucin, but actually interfollicular or intrafollicular mucin. And this most commonly goes along with CTCL, and so folliculotropic mycosis fungoides or folliculotropic CTCL. However, it's not always with CTCL. So, if you read the textbook, there's cases of just what supposedly is just plain old follicular mucinosis in kids, and it doesn't really turn into anything bad. But a lot of these cases are with CTCL. So to check for CTCL, you could certainly look for other features. You don't always see them. And in this one, you don't see a whole lot of them, which is probably why it's just listed as alopecia mucinosa. I should also add that you can get the same thing with cutaneous, like carcinoma cutis, or you're getting metastatic breast to the scalp or something. You can get what appears to be mucin that's like follicular based. But here, if you're looking for features of MF, you'd look for those hyperchromatic, angulated, larger, atypical lymphocytes lining up along the follicular epithelium, analogous to epidermotropism, and you might see the same up in the epidermis as well. You don't really see a whole lot of it here, so you really have to kind of get the CTCL panel and follow the patient clinically to really know whether it's truly CTCL or not. This is a comedone for acne. That's all this really is, and it's a pretty good picture of it. You see this sort of probably an open comedone because it's open to the air, so it's probably black, so a blackhead from the oxidization that occurs, and it's just chock full of newts. And then down below you get this kind of keratinaceous plug and widening of that follicular opening, and that is acne. And of course, if this ruptures or something, that's where you'd get this huge inflammatory response in the dermis. But this is just a comedone of acne. Okay, this one, number 6, is Majocchi's, so deep.
I was going to say deep fungal infection. It's not, a true deep fungal infection like we think of the atypical deep fungal infections, but it's deeper than, in a sense that it's not just a typical tinea corporis in the stratum corneum level. It's actually within the hair follicles, and if not within the hair shafts, and so you have to look closely to see that. I mean, certainly there's a lot of inflammation going on. The skin is not happy. There's a lot of spongiosis. The deep-seated Majocchi's type of tinea really is, produces a robust inflammatory response. And so, getting a little bit closer is where you really start to, see the hyphae and spores and whatnot. In this case, it is Endothrix, so it is actually inside the hair shaft, and then of course that goes with different mnemonics of memorizing what it could be, what strain of dermatophyte. You can see it up here in this follicle as well. So that is a Majocchi's granuloma. So this one is actually a really good example of alopecia areata, and unfortunately, most of the examples that we get are not this good. And sometimes the findings are pretty subtle. Of course, it depends on where you biopsy. That goes for a lot of things. Where do you biopsy for discoid lupus versus LPP versus CCCA versus alopecia areata? I mean, some of those things matter, and of course, as you guys know, if you're biopsying for H&E versus biopsying for DIF, I mean, all those things do, beyond the scope of the next few minutes, but are very important things, and it changes what you see on pathology. But in this case, you're seeing all the classic signs of acute alopecia areata. And so even from scan, you can see that there's a ton of those dark blue lymphocytes that are pretty much only around the bulb of these terminal hair follicles. And so these hair follicles haven't really turned into those exclamation point hairs yet. This is pretty early on. You do over time start to get some miniaturization and some shift towards catagen and telogen, but early on you just see that the ton of lymphocytes around the bulb. And there's some other features you can search for as well. You do want to make sure that those lymphocytes are really just around the bulb, because if they're extending kind of all the way up in a sort of a densely packed vertical pattern all the way up the hair follicle, then that certainly could be lupus. But again, in this case, it's really just around the bulb. And then some of those other features that you look for. Let me see if I can find some good examples here. We're going to go sideways. So you seeing the lymphocytes not just around the bulb, but actually kind of within the bulb, hints a little bit more at alopecia areata, because it's actually targeting kind of most likely the melanocytes kind of here in this area. And then seeing eosinophils is almost pathognomonic. I mean, you can see here, from this altitude, you can see these little eosinophils here. I'll get a little bit closer. But it doesn't guarantee it's alopecia areata, but this combination of dense lymphocytes and eosinophils and maybe even some mast cells really just around the hair bulb is pretty classic for alopecia areata. There are some other subtle features. If you find a fibrous tract, which I think this is probably the bottom of a fibrous tract that's just cut out of cross section. So at the very, very bottom here, you can see that there's pigment that is left within the fibrous tract, and that also points toward sort of the abrupt occurrence of this alopecia areata. You can see that in other cases of anagen effluvium, but and then of course also in alopecia areata. And then those are really the main features. Again, you may see a little bit more shift towards catagen, telogen hairs, or some miniaturization. Okay, that's pretty much it for alopecia areata. chapter 8. And this one is trichotillomania or trichotillomania. And, there are some overlap features between pattern alopecia, believe it or not, alopecia areata, and trichotillomania. And the book really goes through, there's a really nice table in there that kind of outlines those subtle differences. Because with, and I'll get into what you see here in a second, but you can see melanin within the fibrous tract, remnants. You can even see trichomalacia to a certain extent in alopecia areata. So there's some things that are overlap, so it can be a little confusing. But usually you do not see trichomalacia and large pigment casts in alopecia areata, although you can. But here, this is basically that trichomalacia where you're just getting that distorted and shrunken, hair follicle from all the trauma of people pulling out their hair or traction. You kind of see the same thing with traction. And here you can kind of make out a little pigment cast that's there with the trichomalacia. It's right there. And again, it's, as I mentioned before, it's important to note what you do not see. And so you do not see tons of inflammation. You don't see peribulbar lymphocytes. You don't see tons of scarring, although certainly with end-stage traction, you can start to get some scarring. But really all you're seeing here are the absence of hair shafts. There is still one here, so there's still a hair. It looks like there's still a hair in here, but in this follicular unit, it doesn't look like there's really hair left in there. Here, the hair shaft is gone. I mean, they've been pulled out, and so these follicles have been distorted and damaged, and you get that trichomalacia, and you see the pigment casts. So that's pretty good for trichotillomania or traction. Okay, now this one is again one of those extras that's in this chapter. This is Neutrophilic eccrine hidradenitis, which textbook classically occurs more palmar plantar after cytarabine, induction chemotherapy. Of course, a lot of other things can do it now, or realizing a lot of other things have caused it. There's also the idiopathic eccrine hidradenitis that occurs in kids. It's also called Pseudomonas hot foot syndrome. So there's other things that can cause it, but this does not really appear to be acral skin. But from this magnification, you can see that there's something sort of clustering around the eccrine glands, and there's a better cut in here. This cut's a little bit better. So here, these eccrine glands just don't look right. I mean, there's a lot of inflammatory cells around them, although it's a hint pinker than normal, and it's not as well-defined little dark blue dots. So unlike what we see with lupus, with perieccrine lymphocytic inflammation, or other things where you see lymphocytes, this is actually a ton of neutrophils, and hence the name, neutrophilic eccrine hidradenitis. And certainly there's probably a handful of lymphocytes in here, but most of them are these slightly pinker, trilobed, segmented neutrophils. And sometimes you can even start to get necrosis of the eccrine coils. But this is neutrophilic eccrine hidradenitis. Okay, so this is Monilethrix, which is due to what keratin defect? Anybody? It's like 81 and 86, right? I think. Does that sound right? Mm-hmm. So this is where you actually get that twisting in the hair, kind of that little spiraling, and sometimes it can look similar to other things like pili annulati and other hair shaft abnormalities, but this one there's actually that rotational component to it. So this is pretty good for Monilethrix. All right, so anytime you're in the hair chapter and you see a huge chunk like this, that usually means AKN. or acne keloidalis nuchae, which of course is one of those things where there's no keloid in AKN. This is such a large segment of skin that even on 2x, you have to really scan around to see the whole thing. And there's different phases of AKN. There's kind of burnout, scar down AKN. There's early AKN. So a lot of these things when it comes to hair or with anything in derm path, the time course certainly is important. This is kind of run-of-the-mill AKN, meaning that it's a huge chunk of skin. You're seeing these naked hair shaft fragments scattered throughout. You're seeing huge swaths of just scarred skin with separation, and there's really not much else that looks as characteristic as this. Now there is, I will say, some overlap with folliculitis decalvans or dissecting scalp or even hidradenitis suppurativum. A lot of those things kind of look similar because you get scarring and separation, and there's often the hair shaft fragments. I mean, here is obviously like this ingrown hair that's just sort of growing in this little ball there. So you can better appreciate when you see these patients clinically, what's going on beneath the skin when you look at it on derm path, which is why it's so difficult to treat. So this one is in here in the unknowns really just to demonstrate Anagen versus telogen. That's what it's listed. So, and it really does actually do a pretty good job of showing those features. So these are both terminal hairs, because remember there's vellus hairs, terminal hairs, and then there's anagen growing hairs, and then there's catagen and telogen hairs, which really you can kind of lump those together for the purposes of derm path. And so both of these are terminal hairs, really, these two here. But one is really deep, still well-formed, kind of complete normal anagen hair. I mean, you can make out all the layers and the fibrous sheath and the glycogened outer root sheath and the Henle's layer, Huxley's layer. I mean, you can go through all the different layers here. It's a great example of that. You see the germinal cells down here below and all that. I mean, all this is well intact. So that's your textbook, probably scalp, pretty large terminal hair. And then up here is where you see that flamethrower-like appearance of the telogen hair. And so, these anagen hairs, they kind of start to undergo apoptosis and sort of get either pushed up or pulled up or whatever, however they start going up. There's difference in opinion on how that happens. And then you get the fiber streamer below, and as that hair shaft is starting to, in a sense, turn into that club hair that ends up falling out, you see this sort of flamethrower-like appearance, and that is a great example of telogen hair. Now, particularly in the catagen phase, as it's shifting into telogen, but also in the telogen phase, you can make out some like apoptotic cells and maybe a little bit paler appearance to the epithelium that also indicates that. And so the reason I point that out is because you're not always going to see that beautiful flamethrower. And let me see. Yeah. So in this cut, for example, it's the exact same hair, but you don't really see that flamethrower. But even from scan, you can kind of make out, some little pink apoptotic keratinocytes in there. And when you get in closer, when you see a lot of those apoptotic keratinocytes, like all these guys here, that means it's transitioning into catagen and telogen phase, which you did not really see all those in anagen. Okay, so this one is lupus. And it's not the most rip-roaring example of lupus, but it's decent in various respects. So with lupus, it's certainly a differential, especially when you're looking at scalp biopsies, because there's some overlap. So you can get vacuolar interface or lichenoid interface damage and appearance to the follicular epithelium in both lupus and lichen planopilaris. But the areas that are affected and the other features that you see or don't see are helpful in pointing one way versus the other. And of course, there's the elastic stains too, which are, there's some examples in here. But with lupus, the inflammation is largely at the isthmus level of the hair follicle, and you don't really see the whole hair follicle here. But if you can imagine, this long hair follicle that's coming down, if it's predominantly located around the infundibular portion, that's where you're seeing the inflammation, maybe the scarring and the damage and all that sort of stuff, then that points towards lichen planopilaris. But if it's predominantly the isthmus location, so a little bit further down, then that goes a little bit more with lupus. Plus with lupus, there's this classic kind of vertical orientation to all those lymphocytes. You can also see that with marginal zone lymphoma, though. So for those who want to go on a derm path, it's another thing to consider if you see tons of lymphocytes everywhere. But anyway, if you see the vertical orientation, that certainly is helpful pointing towards lupus. Plus, you would see perivascular, periadnexal, perieccrine inflammation, and you can see that here. So there's a little bit of lymphocytic, perieccrine, perivascular inflammation, just like you'd see in other biopsies of lupus. We've been over that before, which you would not see in lichen planopilaris. You also see here sort of some homogenization of the papillary dermis and then a thickened basement membrane, which again, that goes with lupus and does not really go with lichen planopilaris. So when you're seeing all these things that point towards lupus, then of course that makes the diagnosis much easier. And again, it can be very difficult to tease those out if you don't have all these classic features. You also see mucin here, which kind of deeper dermal mucin. It's kind of a faded slide, but even on this faded slide, you can make out some of this stringy, bluish mucin stuff. So, with all those features, it really helps point towards lupus versus lichen planopilaris. And that's, DIF, of course, can be helpful as well. So this is a transverse section or horizontal section of Folliculitis decalvans. And, Folliculitis decalvans is an interesting entity that is hard to sometimes pin down on exactly where it lies. Is it a variant of LPP? Is it a variant of CCCA? Is it sort of all the above? I mean, it's a scarring alopecia with tons of suppuration. So it's sort of a blend between those two, and however it starts originally is hard to say. But in this case, you see some evidence, and we don't have a whole lot of transverse section examples in this unknown box, but there's a lot of people who all they ever look at is transverse sections. So it is good to look at these and to be able to assess them. So with this transverse section, you're not really getting as many hairs as you should. So there's a lot of dropout and scarring. Now it can be hard to tell that when you have all this suppuration in here, but just believe me, there's a lot of scarring going on in here. You get loss of sebaceous glands. And again, follicular unit dropout, and then you just get tons of suppuration, almost like what you'd see with an AKN picture. Not really seeing naked hair shafts. This is just the obliteration of a follicular unit with suppuration. But when you get that overlap between scarring alopecia and suppuration, that's Folliculitis decalvans. Okay, so this one is Folliculotropic MF, and interestingly, unlike the other one that was alopecia mucinosa, this one doesn't really have a whole lot of mucin. Maybe this is a part of a hair follicle, and maybe there's some mucin in there, and that's why when we say follicular mucinosis or alopecia mucinosa, we all think MF because that's what it usually implies, but it can go with other things, non-MF things. And folliculotropic MF doesn't mean that it has to have tons of mucin everywhere. So what you see here is just tons of inflammation that is both at the DEJ, but predominantly around these follicular units. And as we're getting closer, you'll see kind of a lot of the classic features of MF. You've got these jet black, kind of angulated, little hyperchromatic, atypical lymphocytes that are percolating up through the epidermis and the follicular epithelium, and there's some tagging along the DEJ. And there's a relative lack of spongiosis, compared to the amount of lymphocytes that you see. And you may even see some like Potteri microabscesses and stuff like that. So you're basically seeing classic MF. Maybe you'd see some mucin, but it's not required. Okay, so now there's a couple of elastin examples. And this first one is just supposed to be normal. I'm going to flip around the slide. So this is really just supposed to demonstrate normal elastic pattern. And so from scan, you can see kind of the most important things are what you don't see. So you don't see huge clumps of elastin. It's all pretty evenly distributed and mostly horizontal, and kind of goes all the way up to almost the papillary dermis. So there's nothing to see here, which is exactly the point. It's pretty much normal. And as you get in a little bit closer, you can really see that all these elastic fibers look normal. They look healthy. They're not short and stubby. They're not completely obliterated. There's not a lot of inflammation around. It seems to be a pretty normally distributed pattern. And if you can find some fibrous sheaths, it's pretty normally distributed and vertically oriented within these fibrous remnants. And so this is a normal elastic pattern. So alteration of this elastic pattern can be very helpful in trying to tease out the different scarring alopecias. So this first one here is pattern alopecia, and pattern alopecia is not a scarring alopecia, of course, and so really you should have preservation of the normal elastic pattern, and that is kind of what you're seeing here, except you also have the addition of pronounced solar elastosis because there's no more hair to kind of help protect the scalp, and so over time you get a lot of solar elastosis that stains very darkly with that elastin stain. But in other areas, you see a relatively normal elastic pattern to include these normal fiber sheaths. So, if it was some sort of scarring condition, because maybe clinically there's some concern: is this scarring, or is it pattern? So, if it was scarring, you would see obliteration of the elastin within these fiber sheaths or elsewhere, because in scars you don't really get that preserved elastin. And so this is pretty normal, and so it can be helpful to say that there's no evidence of a scarring alopecia. Well, this one is kind of your classic Lichen planopilaris. And so remember before when I was saying that with lupus it typically affects the inflammation, the damage really kind of starts at the isthmus, and that's kind of where all the scarring would occur. And if you did a VVG, you can kind of you can see that a little bit better. Whereas with Lichen planopilaris, it's almost all infundibular location, and so you can see pretty well here this wedge-shaped area of scar where there is no more elastic staining. And around it, there's some, kind of clumping and retraction of that elastin, and that just helps to say that, yep, this kind of confirms that it's Lichen planopilaris, and maybe this is you would do the stain because there isn't a ton of inflammation that's left. Maybe it's more on its way to being burned out, but then you do the VVG and you can see that there's the elastic pattern is gone, and so that's where all that inflammation and scarring occurred, which points more towards lichen planopilaris versus lupus or CCA or something else. Okay, this one, these are supposed to just be hair casts, which can occur with a variety of conditions and things, and so that's really all these are. You can see sort of retained portion here on these hair shafts. So, not very exciting, but that's what those are. Okay, this one is pili annulati, and so you can see that unlike Monilethrix, even though you can get this with these little darker spots here, you don't have that actual spiraling that you get with Monilethrix. So that's what this one is, pili annulati. And unlike a true bubble hair, which I believe is the next one, bubble hair is more usually from hair dryers or abrupt damage. Let's see. Oh no, this is the second example of an exclamation point hair, which really, to me, is just this one here. So the first example that was in here is much better, but maybe there's a little exclamation point there, although it's probably this end. It's not a perfect example. That other one was much better because you actually lost the pigment and it went to a very obvious tapered point or pencil tip. So this one isn't the best example. And this one, I think, is the bubble hair, where you just see this pronounced bubble in the hair. And this last slide is supposed to be overlap between pattern and, I think, LPP. Let me just check. Yeah, so pattern with features of LPP. To be honest, it's a little more challenging, especially with this tangential cut here. Certainly there appears to be some follicular miniaturization and transition to predominantly vellus hairs, because maybe that's what all these little guys are. It's predominantly vellus hairs, and then maybe in a person who had pattern alopecia, then they got lichen planopilaris, and maybe that explains some of this sort of lichenoid follicular interface damage that's occurring here. But I don't really see a whole lot of scarring, and the orientation is a little off to be able to say that, oh, there's a classic wedge-shaped appearance or something that's going on. So this one's a little bit more challenging, and I'm not sure exactly how they got to that, but maybe the clinical helped. So not a great one to end on, but that's hair.